Good morning, and thank you so much for keeping it daybreak this particular morning. We really appreciate you waking up with us and for keeping us company until now. But if you're just joining the show, don't worry. You are just in time for health and lifestyle this particular week. A week that began by the entire globe just uniting to create awareness, to sort of like inspire action and talk about heart health. And this is something that usually happens annually on every 29th of September. Just focusing on how to be able not to miss a beat. That is actually the theme that, we are celebrating this for this particular year. And did you know that's according to World Heart Federation that over 20 million people die of cardiovascular diseases annually. And they say that about 80% of premature cardiovascular disease deaths are preventable. So we are going to be talking about how to make this possible, how to prevent, first of all, that's our biggest concern, how to prevent cardiovascular disease, and also how to be able to manage in the event that you find yourself with one. And that is why I have the expert with me in studio this particular morning. I'll be doing the asking for you, don't worry, and he will be doing the breaking it down for us to be able to understand. His name is Dr. Etienne Amendezo. He's an interventional cardiologist at the Aga Khan University Hospital right here in Nairobi. Thank you so much, Daktari, for creating time for us. He's telling me he's learning a bit of Swahili.
Yes, I am. Yeah.
And it's pretty interesting to have you with us this particular morning. I'd like you, first of all, to start by, I liked the title interventional cardiologist, and I wanted to know more about your work and your area of specialty. It's a basic program, and that's where I'd like us to start this morning.
Okay, well, so interventional cardiologists, so just cardiologists, clinicians who take care of patients with heart diseases. And the bit of intervention involves taking care of patients who require what we call cardiac interventions, or rather catheter-based cardiac procedures. And this, in simple terms, involve getting through someone's heart without opening the chest.
Oh, wow, yeah. Interesting. So you deal with this most important organ in our body, the one that we have represented in front of us. And let's begin there. Talk to us about this organ and, its significance, how it makes the body function, and if it is healthy, this is the heart and this is what it does to us. Let's start there.
Great question. So I'll say, if you ask a neurologist, a brain specialist, you'll say that the brain is the most important organ. If you ask a heart doctor, then I will say that the heart is the most important organ. It is a pump. It is a very small organ, just like your fist, but it does a tremendous job 24 hours around the clock. It doesn't stop. The main function is actually to pump. It pumps blood out of it to send it into the different tissues, and basically to deliver oxygen through the brain, through the kidney, through the legs, through the abdomen, and all other important organs of the body. And so before it pumps, it has to receive, right? It has to receive blood through different vasculature structures. And basically, the main organ is to pump, but also to receive blood and to process it so that it can get oxygen delivered through the body.
All right, interesting. So there you have it. You heard that this is actually the most important organ and in our bodies. And of course, that helps you to be able to function by receiving blood in the different parts of the body. This is what pumps the blood, and the blood actually is what helps to supply oxygen in the body. That's the basic biology. That's the farthest I can go this morning, Dr. Okay. So let's begin straight away. When we were marking the World Heart Day this particular week, what were your key highlights? What inspired you about this year's commemoration?
Very good question. So the theme of this year is don't miss a beat. And basically what it means is that there are so many lives that are lost. And like you said in the introduction, most of these are preventable. 70–80% of them are preventable if people knew what they need to do. And that basically is a call to mind, is a call to everybody, the young and the old, but most importantly, the society at large. It's not an individual concern, it's a societal concern. It's governments, it's policies, it's a society. I think that's how I see it, and maybe in the, we will talk more about this, but it has to be a concern for the society, for us to take care of ourselves. And we see a lot of, diseases that come to the hospital at a very late stage, and we wish to inform the public that people need to take care of them, their health, and it starts at a younger age, and it starts at knowing what you need to do.
And like that, you'll be taking us through some of the things that we do wrong, things that we eat that we shouldn't, and all that later on how to prevent heart complications. But let's begin by just looking at the heart, complications or diseases that you have encountered. What are the most common ones, and which ones concern you most as we're having this conversation this morning?
Oh, well, so that's a good one as well. I think the major things that we see in terms of cardiovascular diseases are diseases related to the heart muscle. The heart muscle at some point gets weak for different reasons, and we call that heart failure. Heart failure is an odd term. It sort of means to the lay person that the heart has failed
to function.
But it actually doesn't fail
you
per
know
se.
What that means.
It's a term that means that this heart muscle weakness, the heart cannot pump enough blood to satisfy the needs of the body, or it cannot receive enough at a normal sort of pressure. And that's sort of the most common problem, or rather most serious problem that we see. But there's also a component of it that comes from what we call coronary artery disease, which are diseases that are related to the vessels that feed the heart muscle with blood supply. And these are diseases that consist in actual blockages in those vessels. When there are severe blockages that impede blood supply to the heart muscle, then people get symptoms, and these are pretty common, and they can constitute a reason to develop heart failure. The other rather most common problem that we see is hypertension. Hypertension is known to everybody. We do see a lot of hypertensive patients in the hospital. Hypertension is probably the most common cardiovascular disease and is the most important risk factor to many serious cardiovascular conditions, including heart failure, like I said, coronary artery disease, what we call acute coronary syndromes, as well as stroke. People who get deficient, or rather inability to get blood supply into the brain and end up developing paralysis or that kind of presentation. All
right, so let's talk about hypertension, because you've said like that's the most common among the population today. Talk to us more about that. What are you reading in terms of numbers, and how does it present? And I've had cases of treatment of hypertension it becomes resistant to treatment. Probably you can tell us a bit about, how you manage that.
Hypertension is as common as, I think it's the most important and most common disease condition of our lifetime. The World Health Organization reports about 1 in 3 adults, people of age 40 and above, being hypertensive.
1 in 3.
1 in
That's
3.
Pretty close.
Yeah. And there is another probably more serious bit to it, is that most of these patients don't know that they have hypertension. But most importantly, even those that know that they have hypertension, they're not controlled. They either take medications, or they know they have hypertension, but they don't take medications. We see about less than 40% of people who know that they have hypertension are given medications, but they are not controlled. And the control, I mean a blood pressure that is less than 130/80 millimeter of mercury. It used to be 140/90, and that's probably what people need to know, that the guidelines have a little bit changed, because we see that people who have high blood pressure of about 135, 138-ish, and 90 and above still get those complications that I mentioned above. And it's important that people know that the threshold for calling yourself a person who has a normal blood pressure should be around 120, 120 something. Basically less than 130 over 80. Yeah.
All right. So what are some of the telltale signs? Because you're saying there's so many people who are walking out there, they have hypertension and they don't know they have it.
True.
So how do you get to know that your system, something is off? You could be having.
It's a very odd disease in a sense that most people will have symptoms of something going wrong in their body. If you have an infection, you usually get a fever. If you have GI upset, you have nausea, vomiting, diarrhea, that kind of thing. But about 50 to 60% of people with hypertension, they actually don't have symptoms. The symptoms are generally weakness, fatigue. You get a bit of shortness of breath. Some people get a headache if the blood pressure is very high. But the majority of people, they have hypertension, they don't have symptoms. They only see that they actually had hypertension when blood pressure is being measured, or when they end up developing a complication, a stroke or heart attack or something like that.
Sometimes that is too late?
Sometimes that's very late, unfortunately, and there is a lot that needs to be talked about in terms of prevention here, because the most important thing that I would say for any person aged 40 and above is to get their blood pressure checked on a regular basis. And just to say it objectively, it would be something about 1 to 3 monthly, you have to get your blood pressure checked.
After every 3 months?
Yeah. If your blood pressure is normal today, 120 over 75, you should check it again in 3 months and see what it is, and check it again after 3 months.
How many people do that, especially? As Africans, even
that's why we're here.
We go to the hospital when we are almost falling or even collapsing. Like the basic checkups are not like a lifestyle for most people. And that's why we're talking about...
Yeah, exactly. That's probably the starting point. And you did mention about something called resistant hypertension. And I wanted to say that resistant hypertension is a different term that we see also in the hospitals. People with high blood pressure who are treated with medications, but their blood pressure is not controlled. And they require many medicines to control their blood pressure, or even with at least 3 medications, their blood pressure is still high, more than 140 over 90. So those are labeled as resistant hypertension. And this group of people are actually about 1 in 5. So about 20% of these people out of a total number of hypertensives in the community, or rather in hospitals. And this group is particularly at risk because if you have your blood pressure at 160 over 100 almost all the time, that exposes you to develop complications we've mentioned. There are sort of 2 subgroups among this group of resistant hypertension. This is what we call true resistant hypertension. These are people who truly take their medications and they've seen a doctor. This doctor has made some tests and has ruled out reasons that they may have hypertension because of other reasons, other malfunctions, other hormonal imbalances in the body that justify why their blood pressure cannot be controlled, but they still have high blood pressure. So those are called true resistant hypertension. Now, there is a group that we call pseudo-resistant hypertension. These ones have hypertension, it's not controlled, they've been prescribed medications plus lifestyle interventions, which we will talk about, and their blood pressure is still not well controlled. And the reason to that is most of the time that they actually don't take medications. Obviously, your blood pressure cannot be normal if you don't take medication.
The failure is on their part.
So there's something called adherence to medications. And we've done many studies to look into this. There's a lot of mental and routine in patients being able to take their medications. And you realize that many people actually don't take medications on a regular basis. And it's tough. It's tough because you have a chronic condition. You go to the doctor, they tell you that you've got to take this medication. your life.
Yeah.
And it's tough. You haven't been counseled appropriately.
Yeah.
It takes time to accept.
Or you could get to some point you feel like you're improving, you're getting better.
Yeah,
Like,
yeah. Some of these will just take medications and blood pressure will improve, and then it will stop taking them.
Yeah.
Or they take them erratically. And some other will just fail to get enough funding or enough finances to buy medications on a regular basis, because these medicines are not cheap. And if you take 3 or 4 medications, it end up being quite expensive. And so there are many reasons to this, but that is a problem in itself, because it just puts you at risk if you take medications on a very regular basis. And indeed, it's also referred to resistant hypertension, although it's probably less of a problem if medications can be taken on a regular basis and lifestyle measures can be applied consistently.
All right. Just before we wrap that up, what options do they have, especially for the ones that you mentioned, the first category, the true, is it true?
Yeah, so the true resistant hypertension is
what do you do as a doctor?
Is a relatively challenging clinic. And so I would say that what we normally do, first of all, the diagnosis of it requires more elaborate history and physical examination and what we call paraclinical workup to try and understand what is actually the cause of the blood pressure being difficult to control. It could be that the patient is getting medications, but he's getting medications sort of at insufficient doses, or he's getting medications that are not necessarily related to the type of blood pressure that the patient has. And so the recommendation is, first of all, to refer these patients to what we call hypertension specialists. And we do have one specialized clinic in the Aga Khan Hospital that sort of deals with this kind of challenging patients, where we work with a number of teams, including kidney specialists and endocrine specialists, to try and identify the actual cause for this person's blood pressure problem. And before we give them the medications, and we base the medication prescription of what kind of problem they have. Yeah. There are also some other sort of interventions that can be done. So basically, the mainstay treatment for hypertension used to be medications and lifestyle. And lifestyle, I would say, consists in obviously reducing salt, regular exercise, increasing consumption of potassium, losing weight if you're overweight, and just avoiding stress and sleeping enough and that kind of thing, which are very, very important actually, because these, if you do that alone, it reduces blood pressure by about 5 to 8 millimeter of mercury, which is good, because if you have blood pressure 155, that falls to around 140, and the measures are pretty different. But beyond lifestyle measures and drug therapy, then there's what we call intervention therapies. There's something we call renal denervation therapy, which consists in advancing a catheter through the groin to go into the renal artery and sort of disrupt or reduce the nerve activations that connect the brain and the kidney. And by doing that, we actually reduce the surge of hormones that stimulate blood pressure. And that's, again, a procedure that we do that helps to control hypertension when it's resistant.
All right. So it's sort of like, in simple terms...
And I'm trying to simplify it. It's much more complex than this.
Let me simplify that. It's an artificial way of helping the heart function properly?
Reducing the blood pressure by use of catheters, by use of small tubes that we introduce in renal arteries, and breaking the communication between the brain and the kidney, which sort of are the main stimulants of the vascular tone that then increases the speed of blood inside the vessels. All right,
now that's the most simple, the simplest way he can explain. So you can imagine how he would explain that to a fellow doctor. Anyway, I know we'll emphasize on the lifestyle, because we'll go big on lifestyle, because that's like the main way of preventing, some of the heart diseases. But let's talk about heart attack, because this is a term we commonly hear regularly. Somebody died of a heart attack, but they don't have to die. There's what can be done also within the few minutes to save a life. But let's talk about heart attack.
Good. So heart attack, by definition, means that the patient presents with symptoms, usually chest pain, but it can be other symptoms such as difficulty breathing or fatigue or what we call palpitations, feeling your own heartbeats, or it can be just a fall, a faint, and you fall, or you're dizzy, or it can be sometimes a cardiac arrest, and I will explain the difference between a heart attack and cardiac arrest in a moment. So it's a variety of symptoms, and what those symptoms represent is actually that there's a certain vessel that feeds the heart muscle with blood that has been blocked. Sometimes it's blocked completely, 100% blocked. Sometimes it's about 80–90% blocked.
So the heart does not receive blood.
The heart at that moment does not receive enough blood, or that particular segment that is fed by that particular artery does not receive enough blood. Okay. And so it just starts paining by the suffering that there's not enough oxygen in that particular area. Okay. And so that's what a heart attack in simple terms is.
So how can you tell that you're just about to have a heart attack? Or and in the event that you do, what do you do as a person if you're alone? And what can people around you do in the event that they suspect that it could be a heart attack?
Yeah, so the most important thing is to sort of recognize that this could be a heart attack, and that can be challenging. Yeah. And the idea is to get to the hospital as quickly as possible. And you can go to any hospital. Probably the best hospitals to go to are hospitals that are equipped with capabilities to treat heart attacks. And if you get to that hospital, then there is a pathway that is adopted that helps to take you through a series of tests to confirm the diagnosis and to offer treatment. And I can go into the details of treatment a bit later. But before you get to the hospital, the ideal is also to have some aspirin. Aspirin is a blood thinner, and it helps to break down the clots. Because usually the issue is that you've got some cholesterol plaques building up in that vessel, and at some point they break. That plaque has ruptured and has released what we call clots. I'm trying to find an easy term to say.
We understand the struggle.
A clot in the vessel. Yeah. And that clot is rich in platelets. And if we give an antiplatelet medicine, it can sort of break it down if it has just happened, and that's the reason to give aspirin. Generally, the recommendation is to give about 4 baby aspirins, so about 300 milligrams of aspirin, and go directly to the hospital and reach the hospital
just sort of like a fast measure, but on your way to the hospital.
On your way to the hospital, yeah. It shouldn't stop you going to the hospital. You have to be in the hospital as soon as possible. The diagnosis has to be confirmed and treatment has to be started. And generally, when a person gets to the hospital, there's a series of tests that we do. Like I said, one of them is called an ECG. At the Aga Khan Hospital, we do an ECG within 10 minutes of arrival. It has to be done within 10 minutes. Usually the ECG would help confirm whether the patient is actually having an active heart attack, whether the heart attack has happened already, or whether, and there are different types of heart attacks. This is the most worrisome one, which is what we call STEMI, and I won't go into the details. That one sort of kills very fast and can lead to chaotic rhythm disorders that end up into cardiac arrest. And cardiac arrest means that the heart has actually stopped working and the person is actually dead and has to be resuscitated. And that's the difference between heart attack. Heart attack means that there's a vessel that is blocked, but the heart is okay, is beating, is fine, the blood pressure is probably maintained. But a cardiac arrest is when the heart has stopped working. When the heart stops working for 6 seconds or so, you're in danger. You have to be resuscitated.
Can a heart attack lead to a cardiac arrest?
Yes, and that's the most common problem, actually. Yeah. That's how many people with heart attack die.
So most people die of cardiac arrest, not heart attack.
So I'll tell you, the people that get to the hospital, most of them will be treated. They will get out okay. Yeah. The majority of people who die, whether here in Kenya or abroad, anywhere in the world, die before they reach the hospital. That's why it's important to go to the hospital as soon as possible. Whenever you get a chest crushing pain, or if you get difficulty in breathing and you can't explain what it is, and it's persistent for 20, 30 minutes, maybe you are exercising or you're walking upstairs, or you're just doing something a little bit intense and you develop that kind of pain, then you have to rush to the hospital very quickly. Whether it's in the morning, whether it's night, you have to get your way to the hospital, get checked. And ECG, like I said, is the most basic test that we do. If it confirms that you're having a heart attack, then you get treatment, the initial therapies that we offer, including aspirin and some other blood thinners. But also, we take you to the cardiac catheterization laboratory, where we actually enter through the artery, through a small tube, and we inject a dye through the tube that helps to see the heart vessels and identify that same vessel that has been blocked, and then unblock it using the same technique.
All right, all right. But how? I'm just listening to you, and I'm wondering. As you know, this week is all about awareness, and not just awareness about the conditions, but awareness about even the interventions. And the issue of misdiagnosis and lack of diagnosis is quite big, if you ask me. And as we have this conversation, if you look at what's happening, there are not many facilities that will do what you're describing. Yeah. Is that a concern for you as a stakeholder?
That's a concern.
And how bad is it in terms of,
That's a concern. And like I said earlier in the discussion, I said that heart disease burden and the rise of the problem, as we see in our times, is not just an individual problem. It's not my problem alone. It's not your problem alone. It's a societal problem. We have to avail infrastructure and training and personnel to the society, to the population, so that it can have access to these interventions and to these therapies, or at least that it could be a referral system that works perfect to get these patients treated as soon as they present.
Currently, where are we at? Let me use a basic example. What are the chances that somebody probably in a village in a far-off county right now is feeling pain in their chest and they are not sure what it is? What are the chances that this person who could be, going through maybe a heart attack or something, get that proper diagnosis at that particular facility that is near them? What are the odds?
That's a challenge still, I would say. In most referral centers, most county referral hospitals, they are equipped to get this type of diagnosis and to know what it is. But as you realize, not many people stay around areas where these county hospitals are. Some people stay in very remote areas, and it can be challenging to get to the main hospital and to get a diagnosis made. And so that's where we need to focus.
All right. So the numbers we were talking about earlier, 80, you place them between 70 and 80, are preventable deaths.
Preventable deaths.
They're very preventable.
If you control... So there are certain things that need to be controlled. One is high blood pressure. We've discussed this quite extensively. But the other one is diabetes. Diabetes is on the rise. It's a very big risk factor for cardiovascular diseases. And the other one is cholesterol. Many people have cholesterol problems, and they don't even know that they have them because, like hypertension, cholesterol doesn't give any symptoms until it's too late. But most importantly, the other one is actually the global rise in obesity. Overweight and obesity constitutes a big risk factor as well for both hypertension, for diabetes, but also for various cardiac diseases. And obviously, obesity comes from poor lifestyle, including sedentary life, people who don't exercise, and eating habits. And obviously, there are also some other things that we don't necessarily control. Urbanization and other environmental factors is a problem. If you live here, where do you exercise from? I mean, there's traffic jam everywhere. There are no parks where you can go for a walk. I mean, we shouldn't use that as an excuse, but the society or the government should also sort of do some bit of organization and put parks where people can go and
be physical,
exercise and engage in physical activities and that kind of thing.
It helps. And even without waiting on the government, you could actually, as a person, take that personal initiative.
Yeah,
when
definitely.
I put up the poster that I was going to be hosting you this morning, one of my friends actually told me she's been working from home for quite a bit, and because of that, then you can imagine her lifestyle changed because she doesn't move around a lot. So she included in her schedule that she'll be going for swimming and, you know, just a particular day where she'll be going swimming and trying to do anything physical so that she can at least be on the move. So that's a very good example on how you as an individual, if you really love yourself, you can actually take the initiative and introduce something physical that you can do to be able to be actively involved in the going-ons around you. But then let's talk about the numbers. We notice that cardiovascular disease, in terms of the statistics, numbers keep rising annually. What are you reading from this? What could be the problem?
I think the same thing that we said is that risk factors for cardiovascular diseases are on the rise as well. We talked about hypertension, diabetes, cholesterol problems. They're rising, and people and obesity. We see more people with, you know, weight challenges, and these constitute the main indicators or the main drivers of cardiovascular diseases. But also aging populations. The lifespan of a Kenyan used to be maybe around 50-something, 60 years. Now people tend to live a bit longer, and the longer you live, the riskier you are to sort of present with these kind of problems. The way I see it is that we have to be equipped with the idea that these diseases are coming up and we should be ready for them, and we should establish both guidelines but also infrastructure to deal with them.
I know you're not a nutritionist, but what would you advise people to in terms of what they eat that you know, really causes a danger, and on the other side, what is it that is a friend of the heart in terms of our daily consumption?
Yeah, very good question. So this is what I tell my patients. I tell them that if you're overweight or obese and you want to lose weight, the simple formula is to try and think of the calorie balance, what you take and what comes out. And I urge them to try and monitor that, control what you eat, reduce the portions. That's probably the most important and the most basic thing to do. Reduce the portions, don't eat too frequently, and don't eat too much. And then be active. Don't live a sedentary life. Now, in terms of what to put on a plate, most people will say vegetables and fruits are very good. If you have pre-diabetes or diabetes, that can be a challenge because they contain lots of sugar. And proteins are very good because they're good sources of what we need in our body to sort of build good muscles. And carbohydrates are good because they help us produce energy, but you should put not as much. Proteins and veggies and fruits, very good. Carbohydrates, not as much. But most importantly, reduce the portions and don't be sedentary. The recommended amount of exercise is probably known to everybody, about 150 minutes per week, divided in many sessions.
All right. Is age a risk factor? Is age, talk to us about age and heart complications.
Age is a risk factor. The more you age, unfortunately, the riskier you are at developing heart problems, be it hypertension, or be it diabetes, or be it cardiovascular diseases in general. And so you have to be mindful of that, and you have to start early to sort of recognize that that as you age, you will have, your body will just be exposed or be at risk of these problems, and you have to do your bit to prevent. Age is not a preventable risk factor, but it remains a risk factor.
Yeah, we get old anyway.
But there's also a component of age that needs to be clarified. Is what we call chronological age and what we call biological age. So chronological age is the number of years that you've lived. Biological age is actually how physiologically you look or how you actually are. And so what I urge people to do is to try and work yourself out in terms of exercise, in terms of lifestyle, to look as younger as you can be.
So that you work on the biological age.
Yes, that way you've worked on the biological age.
You can stay 16 forever, biologically.
You can be 80, but biologically you're 45, and that's pretty good.
It happens.
Yeah.
It happens. We've seen a lot of people who are really advanced in age, but they don't look like
Exactly.
age. Yeah?
Exactly. So that's what everybody should strive for.
All right. In terms of children and the younger population, what are the numbers looking like, those who are presenting with heart complications?
Yeah, so the most common problems in children who are young are actually congenital problems. Unfortunately, these are situations where the kid was born with some cardiac or cardiovascular defect. It's either there's a hole in the heart or the heart valves are abnormally located, or there are blockages in the major vessels, that kind of situation. If they have symptoms, again, they should come to the hospital because these are fixable problems if they present early. If they present late, sometimes it's too late for us to do anything because the physiology has changed and established itself in a way that if we touched the heart to try and close that hole, it may just result into a fatal outcome. So what we urge people to do, if the kid has symptoms of any sort, shortness of breath, chest pain, cannot feed very well, or cannot grow up normally, or whether psychologically or physically, then he should be checked. And we pride ourselves in offering that service, and our teams, the pediatric cardiologists, actually do a fantastic job. I see many of the operations that they do are very, very successful. The success rate is about 80% and above.
I know there's a lot that has happened in the area of technology when it comes to interventions. Probably you can also talk to us about that, just to see the possibilities that are out there for people who maybe need those kind of services.
Yeah, there's a lot of technological advancements. I talked about catheter-based treatment of hypertension and heart attacks or blockages in heart vessels, but there are also interventions that consist in treating valves. Somebody who's got a valve that is blocked. You know, the heart has got 4 valves, as you know, 4 cavities, the upper chambers, the lower chambers.
And feel free to show us.
So
that's why we...
On this one, the heart has 2, what we call the ventricles, the bigger chambers, which are the lower chambers, and the atria, which are the upper chambers. And in between those, there are valves. There are 2 valves on each side, on the left and the right. And then the right ventricle that sends blood into the lung to get oxygen and get rid of carbon dioxide has to go through what we call a pulmonic valve, which separates the right ventricle and the pulmonary arteries. And the left ventricle that then sends blood, the big pumping chamber of the heart that sends blood into the aorta, which is that big vessel that sends blood into the system. They are separated with the valve, and we call it the aortic valve. And so there are technological advancements that include actually the capability to treat, for instance, the aortic valve without opening the chest. And what we do is we go through a small hole in the groin using that same technique that I mentioned earlier. And we insert tubes, and on the tubes we actually mount a valve. The valve is generally made of either a cow or pig membrane, and we send it all the way into the aortic position. And we inflate it with a balloon that helps to expand the old valve and sort of open up to fix a new valve, and then we remove our equipment, and it just takes 45 minutes to do. It's sort of replacing the actual...
the cow and pig membrane remains...
Oh, remains in situ, it remains inside.
It does?
Yeah,
What's
it
the
remains
level
inside.
of acceptance? Like it just gels and functions?
Yeah, the body accepts it very well. We do use just baby aspirin in that patient to make sure that the valve does not attract clots or platelets and closes up. But otherwise, most patients tolerate it fine. And we've done many of these procedures at the Aga Khan University Hospital, and patients are very, very, very well.
All right. But then again, I've heard you mention, and it's not just once since we started talking, you know, interventions that do not involve opening of the chest. Maybe you could tell us a bit about why this direction, why this inspiration to really be minimal in opening the chest.
So first I have to clarify something very important. It's not that open heart surgery is obsolete. It's not that it's gone. No, it's not. It has its role, and we do have very able team that deals with this kind of surgical procedures that require open heart surgeries. Very important. But as the world evolves, we've been lucky enough in our lifetime to see that you actually don't have to open the chest and crack the chest, open the clavicle, open the sternum, crack the chest, open it, and put the patient on an artificial machine to help the patient breathe and to help the patient, you know, circulate blood and stop the heart and work on it and then start it again and put the patient back from the machine into connected to the heart. And that's how it happens, unfortunately. But over the years, researchers have found different techniques and different, you know, ways of resolving the problem without needing that, because that's quite heavy for the patient. Usually the patient has to stay in the hospital for about 5 days or so. If you do what we do with going through using the catheters to go through the vessels, then the patient goes home in 1 to 2 days, and the outcomes are relatively the same. But we have to think through this very critically. It depends on what we're doing. We analyze a lot, and we don't just take the decision. We inform the patient. Usually the cost implications are also an important aspect to look at, and we do a lot of that as well to help the patient.
So there are cases where open heart surgery is necessary
and there are cases where these type of interventions are just good to solve the problem without opening the chest.
All right.
Yeah.
I want to talk about whether it can recur. You know, you've been treated, whatever it is that, you know, you are dealing with, you've been treated. What are the chances that, you know, it can recur? And you can also take this opportunity to share with us some success stories if,
Well, that's a very important question, I'll tell you. Because you have to think about the way the patient presents. There has to be something has gone wrong for a person to present with a heart attack. Sometimes it's not the person's fault. It's just the way it is. Genes, the way you're born. Maybe you've got sort of misplaced arteries, or you're just unlucky. But sometimes it's the things that you've done or not done. Lifestyle, we've mentioned, poorly control hypertension, poorly control diabetes, and then you end up developing a heart attack. Say you've developed a heart attack, we've come to the hospital, we've done our job, we've fixed it, and you're going home. So there are certain things that we tell you to do, and if you do them to the letter, hopefully then there's no recurrences. Recurrences are not as common. Maybe 5 or less than 5% of people represent to the hospital with the same problem. But those things that we tell people to do include taking medications, because if you present with a heart attack and you have high cholesterol, you have to be on a cholesterol medicine to try and reduce that, that cholesterol surge in the blood that then ends up going into the vessels and blocking them. You have to control the blood pressure, you have to control diabetes, you have to control weight and all that. But most importantly, you have to take some blood thinners to try and reduce the risk of what we call a stent that we place in that area where we've treated blockage so that it keeps the vessel open. And we give blood thinners to make sure that the stent does not occlude again. But it's not just that. We also tell people that they need to abide by a lifestyle. And in this, there's a set of services, including what we call cardiac rehabilitation service.
That's after the treatment.
That's after the treatment. Yeah. The cardiac rehabilitation services are very important in a sense that they teach people what to eat. They teach people not to smoke. Some of these guys will be smoking even after having a heart attack. And they help people recover gradually. If you've developed a heart attack, understandably, your heart has been shaken, and you have to sort of recover progressively. And the cardiac rehabilitation services, which are present, we have one service in the hospital, but also there are services around the city that offer, a pretty good cardiac service.
Thank you so much.
Cardiac rehabilitation services. Yeah.
Thank you so much. Unfortunately, because of time, that's the much we could cover. But in 30 seconds, what's your clarion call on this week and month that we were actually talking about heart health?
Good. So my take-home message is that people need to get checked. Checkup is very important to know where you stand. People have to measure their blood pressure, and people have to think about lifestyle. If you're 25 now, or you're 40 years old, and you don't have anything, you have to start doing certain things to prevent that something may happen in the next 5-10 years. Right. If you have high blood pressure already, you have to think of, if you do nothing about it now, or if you take medications erratically, in the next 10 to 15 years, you have developed complications related to hypertension. And those include, like I said, stroke, heart attack, heart failure, chronic kidney disease requiring dialysis, and that kind of, bad stuff happening. We've seen people at 55 years, 60, they are dialysis dependent because they did not take
action.
And it's not that I'm sort of saying that it's just that they didn't know, or that they were misguided. And that's why we're here to talk about this and to make sure that everyone gets the message. The checkup and taking care of your health is as important as anything. But most importantly, it's not a person's job, it's a societal job. We have to combine efforts to combat cardiovascular diseases.
Thank you so much, Dr. for creating time. Of course, on top of that, early screening is really insisted. We also need to put in place policies that will ensure affordable access to care, more opportunities to make healthy choices in nutrition. That's a personal decision you can actually make today. And of course, the most basic one is just to stay active. Stay active. Anything that you can do to stay active, that's a friend of the heart. Thank you so much for creating time for us today. I was having the sit down with Dr. Etienne Amendezo. He's an interventional cardiologist at the Aga Khan University Hospital right here in Nairobi. Asante, Daktari. And thank you for watching Health and Lifestyle this Tuesday. Enjoy the rest of your viewing and enjoy the rest of your week.